I am one of those annoying people who always wanted to do medicine. And when I went into medical school, I had no real idea what I wanted to do. Although the very first person I met for a project as a supervisor was a paediatric neurologist. I then did my elective as a medical student in child neurology in Australia and really loved it. So always knew I wanted to do child neurology. When I had finished my paediatric training, there were only 2 places in the UK you could go to do child neurology, Great Ormond Street Hospital and Manchester. And I applied for the training post at Great Ormond Street Hospital and got it. When I arrived, we just had the first MRI scanner, clinical MRI scanner for children installed in the UK. And serendipity, as much of my career has taken a course through that, was that we were looking at children, at their brains, much more detailed fashion than we'd ever done before, and particularly of those with epilepsy. And my then supervisor, my mentor, really thought, could we do epilepsy surgery more effectively in these individuals? So that was my PhD about imaging in children with focal onset seizures. It's not only MRI, but also SPECT. I got very involved in developing the epilepsy surgery program, and then I was hooked. And complex epilepsy and improving outcomes in complex epilepsy through whatever treatment and now diagnosis was very much what I wanted to do as a career. I think the services for epilepsy, particularly childhood onset epilepsy, which is what I'm involved in, have really improved and become world-class over the past 20 years in the UK. That said, we have an NHS system which is really beginning to break at the seams is the wrong thing to say. It's just creaking with the sheer numbers. So whereas we have all treatments available to us, particularly for all the different stages of epilepsy, the care pathway could be improved. Long waiting lists, not seeing the right people, having a real clear care pathway is something that at present we are working on. We have an NHS England transformation programme for childhood epilepsy, and part of that is improving access to care, improving access to mental health facilities or interventions for children with epilepsy, as well as improving access to epilepsy surgery. For epilepsy surgery, we have a centralised service in England. We have 4 centres that are responsible for evaluating and undertaking epilepsy surgery in children, and that's been in place since 2012. It's really increased the numbers that have been moving through, but we could do better. The most important things to know about ketogenic diet are: 1, it's not a fad treatment, it's a real medical treatment. Number 2, it can be very effective in epilepsy. Number 3, it's not easy. It does need careful monitoring, but that doesn't mean to say it shouldn't be offered when an initial 2 drugs have failed. The ketogenic diet has long been around. There's been a lot of concern about, particularly in those not in the know, about it not being palatable, difficult, lots of side effects. But we know when it's undertaken properly, particularly in children, it can be very effective and give the families a degree of control about what's going on. Yes, we have to monitor for side effects, just like we would with any other anti-seizure medication. And we can adjust the diet accordingly, particularly if there are gastrointestinal side effects. In older children and adults, it is more complex, and much of the problem is the lack of resource in order to implement it. In children's services, we usually have dietitians, and therefore it's relatively not easy, but relatively straightforward to set up a ketogenic diet service. In adult neurology settings, there is a lack of dietetic availability, and that's what's the main restrictive issue about implementing the ketogenic diet in adults.